Okay, so it is my great pleasure now to introduce Professor Cynthia McCulloch, who'll be delivering our lecture this evening, Milestones in CT, Past, Present and Future. Cynthia is the Brooks Holland Professor at the Mayo Clinic in Rochester, Minnesota, and she holds the rank of professor both in medical physics and also in biomedical engineering. She has over 500 peer-reviewed papers, which include some historical essays, as well as multiple NIH grants related to CT imaging, and has served as the president of both the American Association of Physicists in Medicine and also vice president of the International Society of Computed Tomography. So we're very privileged to have her speaking to us this evening. Just one item of business. We will take questions at the end, but if you could put your questions in the chat, and I'll keep an eye on those, and we'll try and get through as many of those at the end. But on that note, it's over to you, Cynthia, and we're all very keen to hear your lecture. Thank you.
All right, thank you so much. Okay, I have a bit of a cold. My voice isn't usually like this, so please bear with me if I have to stop and take a drink. I am very pleased to talk on this topic. CT is kind of what I do, so I have been privileged to be part of some historical things. There are other people on the line here that even more so. So it's a privilege to talk to the British Society of the History of Radiology. So I'm going to talk about the past a bit, present and future. These are my disclosures. So let's talk about the history of CT. The story doesn't begin with the characters, the people that we know and typically think of. It starts much earlier. In 1917, Johann Radon, a mathematician, solved what we call the inverse problem from a mathematical perspective. So he figured out how, from taking measurements through the outside, one could solve what was in the inside. This was, of course, well before the age of computers, and it was a purely mathematical approach. In optics, they did back projection in the 1940s and used a sinogram to reconstruct an image. In radio astronomy, Ronald Bracewell used strip integration, much like doing just one row of a detector. And I found this out just recently. It was tremendously interesting to me that there is reports of a medical CT scanner that was constructed in Kiev by Tettelbaum and Kornblum. And the documentation of this is sparse, but supposedly they built the scanner and then one of the two passed away quite young and the project didn't go anywhere. There was further work in radio astronomy where they then went to the fan beam approach, work in electron microscopy, and then more work in electron microscopy. And if you really start digging into the literature, it becomes clear that a lot of people were fascinated with this problem, working on it from many different fields of science. Now, these slides are courtesy of colleague Norbert Pelk, and he shared with me this story that I had not known, that Siemens was doing some R&D on the idea of creating a cross-sectional image from attenuation coefficients from X-ray transmission measurements. But radiology at that time was very focused on improving spatial resolution, and they felt that their technique would only be useful if it approached the resolution of radiography. But sufficient computational power and the detectors wouldn't be available for decades. So they stopped the project and nothing was patented, nothing was published. By this time, Godfrey Hounsfield was almost done with the prototype scanner. Now, their reaction when they found out about Hounsfield's scanner was one of astoundment, and they couldn't believe that they were only 80 by 80 pixels, a third of what they, or 1/30th of what they had thought necessary. And they realized they'd been so focused on spatial resolution, they had not appreciated the significance of density resolution and being able to see low contrast objects by removing all the superimposed tissue. The project was, of course, then reinitiated. And if you have something to write with, I'm going to give a few references to things that you can watch on your own. If you Google search YouTube for Norbert Pelk Mayo Clinic, talk that he gave on the anniversary of our 50th anniversary of CT is there on YouTube, and you can watch that and some of the other lectures from that day. Norbert talks a lot about the history also of what happened at Harvard, and it's a really great presentation. So now to the individuals we most associate with CT. Alan Cormack was a physicist from South Africa, and he was working at Tufts University at the time and dabbled in radiology somewhat on his spare time, worked a little bit in the radiology department, and published 2 papers about finding out the inner structure of an object from transmission measurements through the object. They were fairly mathematical papers, but he did build a prototype system, a desktop system that you can see in this photograph with him, and create an actual measurement that worked. He talked to the people he knew in radiology and got 0 interest. So he published these 2 papers and walked away from it, seeing no interest in the medical community. Now, completely independent of Cormack, Godfrey Hounsfield, who was an engineer at EMI, started to explore this idea, and he proposed a project. This is a picture of the project proposal to investigate using a computer to make better use of the information obtained when an object is examined by X-rays or gamma rays. He was a much more pragmatic man, not trained in pure mathematics, and so his approach was much more visual. He sketched out what it would look like and what the projections would look like and what the cross-sectional images would look like. He also built a tabletop system. Here, this is the original lathe scanner that he built, and there's a breast specimen on an acrylic block. Here's the X-ray tube, the detector. They rotated with a musical phonograph turntable, which I think is fitting considering EMI's other endeavors in the musical industry. And the data had to be reconstructed on a mainframe computer. This is the image that was obtained in 1969. Took 90 meters of punched paper tape, and I'm old enough to remember punched paper tape. So this was a huge amount of data at that time for a computer to handle. With this evidence in hand, he was able to get some funding from the British government and a little bit more from his employer EMI. And then in 1971, he performed the first CT scan of a patient on October 1st. This was done in conjunction with Jim Ambrose, who was a radiologist at Atkinson Morley's Hospital in Wimbledon. And here's a photograph of the actual scanner. And the one on the left was from a movie, I believe, well, it's in one of the movies I've seen, of Godfrey actually explaining how the whole thing works. And this was the first image that they obtained with a mass in the frontal lobe. And the excitement was palpable. I think I've seen a quote somewhere that they were slapping hands like footballers. Excuse me a minute. So, which leads us to what we're probably all aware of already, that they shared the Nobel Prize in Physiology or Medicine in 1979. This was only 8 years after the first image demonstration. Really, 1972 was when they started to share information with the world about this. I've got more focused on these early days in a section of the AAPM Virtual History Museum. So if you go to this link, museum.aapm.org, you can see virtual presentations about lots of imaging modalities and radiation therapy, but there's one there on CT. And I didn't want to spend too much on these early days because I'm talking to an audience from Great Britain, and assume most of you know most of these details. And in fact, you've got some of the experts who I have looked at their resources on the call today. Now, there's a movie that we made, and Richard Walton was extremely helpful to our director in digging out information. If you Google a new way of seeing, you will get to this movie. It's about 20 minutes long, and it talks about the early days of CT. Mayo Clinic received the first commercial unit, so we have serial number 101. That's a photograph of the unit in our radiology department. We keep it. It almost made it to the landfill a couple different times, but one of our radiologists who had been a resident when it first came kept telling people, this is going to be history someday. This is going to be history. Don't throw it out. But because of a number of close calls, he finally put big signs on the crate that said radiation equipment danger, and nobody tried to throw it out after that. Now, Hillier Baker, we knew him as Bud Baker, was the radiologist that went over and met with Godfrey Hounsfield and the executives at EMI to bring this scanner back to Mayo. And Mayo is a fairly conservative organization, but he was literally given the authority to purchase it on the spot if it appeared to him that it would do what the claims were that would do. So he was one of the founders of the story of the use of CT here in the United States. And the issue of the American Journal of Radiology, Röntgenology in 1976 was all about CT. And so I've taken some information from that journal article. These are graphs from the paper that he wrote. And in the upper left, you can see the number of CT scans. Everything is normalized to 1,000 neurologic patient registrations. So how many patients were coming to the clinic and how many of them were getting CT scans, and it's a monthly volume. So you can see the sharp rise, and then it seems to flatten out. That's because we'd reached as many as we could really do in a day, and so a second unit was installed. Now, EEGs, electroencephalograms, stayed pretty constant because they're measuring a different property of the brain, as did angiography, looking at blood vessels. But nuclear medicine for brain imaging started to fall off, ultrasound fall off, and the dreaded pneumoencephalograph exam, which was really horrible for the patients. They were strapped into a chair and air injected in their spinal column and rotated around so the air would go up into their brain. After the second unit had been in for several months, these were discontinued and a thing of the past. So CT ended this, and when people are concerned about radiation dose with CT, I like to explain to them what a pneumogram was and the kind of tests patients had to endure prior to CT. Now, this is one story. When we had our 50th anniversary, Mayo put a little blurb in our local newspaper, and a woman contacted me and told me her story that she was 10 years old, riding her bike, took a fall, didn't appear to be hurt, but her cognition began to regress. So they took her to the emergency room at St. Mary's Hospital, and something was wrong, but the x-rays and all the rest of the tests didn't show anything. And we had the CT scanner at St. Mary's, and then the source of the problem was revealed. She had a baseball-sized epidural hematoma, life-threatening, and that required immediate attention. So she went into surgery. 10 days later, she was home, bald but healthy little girl, and incredibly thankful for this invention and living in Rochester, Minnesota, when the scanner really wasn't available in many places yet. So now let me switch to milestones beyond those very early years and the rapid evolution of CT. This is a picture of Godfrey Hounsfield and James Ambrose with the EMI 1010 head scanner. And I didn't point it out, but on the original scanner, there was a rubber holder here that was filled with water to help the attenuation on the sides of the head not cause so many artifacts with the detector. So they had gotten rid of that. It looks somewhat like a modern CT patient table. And with the success, the next logical step was to turn to doing this in a body. The head stays relatively still compared to the body, where you've got breathing, you've got diaphragmatic motion, you've got the bowel moving. And so they had to make things faster. Generation 1 is the scanner that the EMI Mark I that Hounsfield developed. And then they started to make things a bit faster by opening up the collimation to get a small fan beam. And that improved the temporal resolution, or the scan time decreased. They really then needed to move even wider to this fan beam geometry. And for a time, there was called Generation 4. The detectors were on the outside of the ring surrounding the patient, and the X-ray tube moved around on the inside of the ring. The fourth generation geometry, it went away. It wasn't particularly dose efficient. It didn't have good scatter correction because it couldn't put scattering anti-scatter collimators in direction of the X-ray beam, because the X-ray beam kept moving. So this was the path towards body imaging. And I've got several different images in this talk showing then and now. These are some images from 1973, when our scanner was first put into clinical use. And this is actually the same patient 30 years later. He just happened to come back, tell us about his prior scan, and we were able to find the images and make that comparison. And for our 50th anniversary, I pulled together some current brain CT images. And the most striking difference is now the data are isotropic. We have equal spatial resolution in all directions. So we don't have to live in just the axial plane anymore. We can create sagittals or coronals, or we can make really exquisite 3D renderings and volume reconstructions. So that's a little bit how brain CT has definitely moved forward. This is an example of lung imaging, early example from the body scanners. Mayo had the Emerald one, I think it was, the Emerald, in the 1975, 76 timeframe. So this is from 77, a little ways into that. And these are the type of lung images that we can make now. The same for the abdomen. The gastric motion here gives a lot of motion artifacts. We can see very small liver nodules here in modern images. And again, we have isotropic resolution, so we can look here in the coronal. We reconstruct coronal images all the time now. It's a basic part of the scan because it helps put the anatomy into a perceptually easier way to understand, and the referring physicians really appreciate it. Now, another piece of history that probably is overlooked by people outside the Mayo Clinic is something called the dynamic spatial reconstructor. It was this huge machine built with NIH funding. This is the gantry, and there were 14 X-ray tubes and 14 detectors. And the detectors were image intensifiers, the kind of detectors they used in fluoroscopy. And so you could get very rapid imaging by quickly pulsing all the X-ray tubes and getting rapid data acquisition in a planar format on the image intensifier. So this was built in the late 70s with NIH funding, and some of the leads in the project went on to have really prestigious careers in CT. Dr. Eric Rittman, Earl Wood, Rich Robb, Barry Gilbert are still at Mayo doing research in digital imaging. So this was from a publication in Science. Now this scanner, because it used image intensifiers, would never have the contrast resolution that real CT scanners have. It's more of a cone beam CT scanner, and so it had all kinds of scatter. So in order to see the coronary arteries, which was their goal, they had to inject the iodine right into the coronary arteries. So it was a direct injection, much like happens in a coronary cath lab exam. So here are 4 time points of the coronary tree. This is a volume rendered exam from our photon counting scanner, which I'll be talking about a bit towards the end. And you can see this stent. You can see the right LAD, left circumflex coronary arteries. You can see the papillary muscles and even see a coronary vein. So the dynamic spatial reconstructor was the first machine to visualize the coronary arteries. How Godfrey Hounsfield envisioned imaging the heart in some of his first papers. And the time was just not right to do it. Even at this point in time, it wasn't really able to go clinical, but they said, you know, at some point in time, if they get a scanner with better density resolution, perhaps we can do this with a peripheral vein injection, not injecting right into the heart. And these are modern scans of what we can do now with just an injection into the arm. You may notice that this image gets a little noisier during systole when the heart is in its squeezed position. That's because we modulate the tube current or the dose. You see the coronaries best at end diastole, so we use the most dose there, and then we lower the dose so we can just see the ventricle and the valves in the other phases. So then after the dynamic spatial reconstruction, there was kind of a quiet period. And I found this brochure in our archives. I think this was from Picker, who is no longer around. And they made the claim that the time had come, they had the ultimate CT imaging system. And essentially people said CT is dead. And most of the research groups working on CT moved over into this new technology that was arriving called MRI. So there weren't a lot of groups still working on CT in the 80s. But there were a few, and they thought they had to think out of the box to take us from this plateau that we were at. One was a man named Doug Boyd from University of California, San Francisco. He was a professor there. And he created a scanner referred to as electron beam CT. And he said, if we want to image the heart, we have to scan really fast. If you're trying to move this several 100-pound X-ray tube around, you've got limitations. So let's not bother having an X-ray tube. Let's instead just move a beam of electrons. So this is the scanner from the patient's side, and behind it would be a wall that would cover up. And the wall would be about here, and would cover up what looked like a physics lab. They had a 9-foot-long electron beam drift tube, and the electron gun, and the magnetics steered the beam very, very quickly in 50 milliseconds around detectors that were somewhat like fourth generation. I misspoke. Not detectors. Detectors are up here like fourth generation. They steered and hit the tungsten anodes. And this is where they created the X-rays that went very quickly around the patient. The detectors were about 210-degree fourth generation like non-moving detector array. And the whole field of looking at coronary calcification to predict coronary risk came out of work done on the Imatron. Here's an example. And then we had spiral CT. And I do want to mention, and I'll put the link in the chat right when we're finished, that we lost a pioneer this past month. We lost Dr. Willie Callender, who is widely regarded as the father of spiral CT. And I have a memorial board that people are putting their thoughts and comments on that I'm going to send to his family. So I'll post that link when I'm done. But Willie had the idea of moving the patient table while the X-ray was rotating. And most people thought that was just the perfect recipe for artifacts, because after all, you want, during the time of data collection, the patient to be absolutely still. But he believed that with appropriate interpolation, mathematics could handle and re-register the data that was unregistered, and spiral CT came about. This was a huge milestone in CT and reinvigorated the whole field. A spiral exam was contiguous, so you didn't have any more of the one slice at a time, and if the patient moved or took a breath, you had discontinuous slabs of information. The early spiral CT scanners could cover about this much information. The limitation was in the X-ray tube as much as anything. Modern systems can do this and in fact do the whole body. Then later in the 1990s, some research done primarily by the CT vendors said, you know, instead of just having one detector element along Z and setting up our slice width by the collimation up here, what if we sliced and diced our detectors and had an array of them? Opened up the collimator, we could cover more in the Z dimension, and each detector is smaller, so we'd have better spatial resolution. So this was the birth of multi-detector row CT, also known as multi-slice CT. So again, looking at the path of a spiral CT moving around a patient, we had limited scan coverage per rotation because it was just the width of the one collimated X-ray beam. With multi-slice CT, we had these different stripes that were being collimated, if you will, at the detector level, not at the X-ray beam level. So this gave us more coverage per rotation, which gave us shorter scan times, and then we had thinner slice reconstructions available to us. So this was state-of-the-art in the late 1990s, just about the turn of the millennium. And then things heated up, and we went through a period that is referred to as the slice race, because every RSNA, which is the big show where the vendors come and display their newest technology, the vendors were trying to leapfrog one another and have more and more detector rows along the Z-axis. Now, when they were in the early days, there was a dose inefficiency. I'll show you in a moment. But by the time we got to wider detector arrays, and even this large one that at first only Toshiba, who is now Canon, only Toshiba pursued, but others have it now as well, you could acquire one rotation and get all the information you needed for some organs. You could get all the kidneys in one rotation. You could get the brain in one rotation. And so that made things quite a bit faster in these wide array systems. So this was the slice race. And vascular imaging was one of the litmus tests. Again, in the early spiral days, you had about this much coverage. Now we can do a spiral scan from head to toe, and using a special mode on a dual source scanner, which I'll talk about, you can do this in 2 seconds. So this is an early picture of spine. They were very pleased to be able to get continuous images, but the resolution at any given point is still poor because they had this wider collimation. This is actually a CT data set, and it's a virtual volume rendered image, and the light that is cast on the data, it makes it look like you're looking at a photograph. Here's a tibia fracture, then and now. And so CT growth went through the roof. In the 90s with spiral CT, many more applications became available, including angiography, which displaced a lot of catheter angiography. So during that decade, CT was growing about 10% per year. And that made some people concerned about the amount of radiation dose collectively to the population because so many CT scans were being done. So one of the manufacturers, again, Willie Callender was a pioneer in this work, said, you know, we don't need the same tube current or dose for every projection around the patient. When we're going in the anterior posterior direction, we can turn the dose down because they're thinner than they are in the lateral direction going through the shoulders. So this is what the tube current might look like going through the shoulders, down into the lungs, and then you hit the diaphragm and need, you've got more moderate attenuation, whereas the lung was low. And so then you go up and come down in the pelvis. And so these are four reconstructed slices, and you can see the different tube current, which is directly proportional to dose at the different body regions. This reduced dose 40 to 50% in a lot of cases. So it was a great technical milestone, made a lot of sense. Another milestone that I want to mention is what we're doing here at Mayo now. In 2004, we opened the CT Clinical Innovation Center. We have this rich history with CT. And at this point, we partnered with Siemens. These are a couple of people in charge of Siemens CT at that time, Thomas Flor and Bernd Onerzoga. This is me and my medical director, J.G. Fletcher. And we opened this center with the sole purpose of, creating innovations that would have high impact and translate into patient care. So we didn't have the typical CT scanner in a clinical practice that you had to scan a new patient every 15 minutes or every 20 minutes. We had this scanner in a special area where we could take the time we needed to fuss with the protocols, to change the reconstruction parameters. And so we started our journey, as I mentioned, the 64 slice scanner. With multi-slice CT, you need the umbra part of the X-ray beam, the part that's pretty flat, over all your detectors. And the penumbra is wasted radiation on the side. So in the 4-slice detector rows, there was a big waste of radiation. The 64 slice, this went down to low enough that as a percentage of the whole dose, it was not bad. And so 64 slice is sort of the milestone where we began reconstructing in the 3 dimensions or the 3 planes on a routine basis. Then another thing happened. We were scanning cardiac images, coronary angiography took off, but it was not as fast as an Imatron. And Imatron had sort of, the electron beam CT had sort of set the benchmark, if you will, at about 100 milliseconds for a cardiac scan. Rotation time in that era was, sub 1 second, maybe 375 milliseconds. And so your coronary angiography temporal resolution was about half of that. And spinning it much faster became increasingly difficult because they went from 1 second to half second to 0.375 seconds to 0.25 seconds, 0.24, 0.23. It was a point of diminishing returns. The physics and the G-forces, they just can't spin it much faster. So Siemens looked at it and said, how could we make the scans faster and get less temporal artifacts? And they went back to the dynamic spatial reconstructor idea and said, let's use multiple X-ray tubes. So there were 2 X-ray tubes, there's 2 X-ray detectors, and this is one of the early images we made with the 85 millisecond temporal resolution. So for the first time, a conventional scanner with a spinning X-ray tube passed this benchmark that Imatron had set. Now, once you've got 2 X-ray tubes and 2 detectors, the idea of dual energy came up. And I didn't put any slides in this, but Willie Counter was also a pioneer working with Siemens in the mid-80s, and they used dual energy CT techniques. Basically, the material attenuates based on the energy and the atomic number. So if you have materials that have different atomic numbers, you can separate them. So with the 2 X-ray tubes and 2 detectors, Siemens brought back the idea of dual energy CT. And so we've got this nice angiogram of the head and neck, and you've got the bone blocking all kinds of the vessels. It was really laborious for a technologist to scalpel digitally out all those bones so they could see what was going on. And so then with a click of the button with Duran GCT, you can actually show just the vessels because the data know which are calcium voxels and which ones are iodine voxels. There were a number of different iterations. This was kind of a fun time in CT. Siemens had the dual source approach, GE and then Canon do the KV switching. Siemens did the split filter for single source. Philips did this dual layer detector. And on any scanner, you could do kind of repeat, step and shoot, but you got too much motion between the data sets. So these are the different technologies that we use with Duran GCT. The 256 slice CT became commercially available in 2008. So that's kind of the end of the slice race. And as I mentioned, you could image one whole organ, certain organs, such as the brain, in one rotation. So this really gave very nice brain perfusion images. So in 2010, again, this dose topic was out there because CT just continued to grow. Every time the technology got better, more applications came with it. And so iterative reconstruction was pursued rather than filtered back projection. And the whole idea is you take some initial guess, could be just uniform water image if you want, and you synthesize projections. This is what we think this object would look like. Compare it to the real projections, and depending on the differences, you go back and update your first guess. And you can use knowledge about the noise and the statistics in your data and your measurements. You can have physics information that helps you how to update this image. And so this was iterative reconstruction. And this was very thin reconstructed images, probably 0.75, 0.6. And it's very noisy when you do a coronal. With iterative reconstruction, it looks just beautiful that the noise all appeared and this was going to save everything. But look closely. Here along the Z direction, the femoral head and the acetabulum blur into each other because there was blurring along the Z-axis that was happening. So iterative reconstruction was quickly adopted and then later found to have some problems. And with any early technology, there's a strong demand because it's really exciting. So they want to make it available as soon as possible. But sometimes we don't find out the unanticipated problems until we've used it a while. And so one of the things my lab works on is much more rigorous evaluation of new technology to try to find these unanticipated effects before we get there. But sometimes the horse has already left the barn, and that's what happened with iterative reconstruction. And I'm going to skip this graph and go right to what we learned. Everyone believed iterative reconstruction improved your low contrast detection because you had lower noise. And early studies only looked at noise. They didn't look at diagnostic performance. But the truth was, and that's what those graphs were, that the edges of a low contrast lesion became degraded and got blurrier. So for example, one detector, this is the phantom up here in the right. This is a very high dose. So this is the object pattern that is in this phantom. And at filtered back projection at 100% dose, you can see the lesions that you can see. At 25% dose, which is what the scanner manufacturer said to use, you certainly don't see all the same things. And so this was the problem with iterative reconstruction. I'm going to skip this. And we determined that you can't go down anywhere that low, maybe around 78%, you get similar diagnostic performance. And I skipped the slides that represent that information. But even then, you still don't get back all the low contrast resolution that you had. So iterative reconstruction helped lower the dose. For high contrast tasks, it was great. For low contrast tasks, it had a strong weakness. And these are patient images. We had a practice that was very excited that they were the lowest dose. It was one of our satellite facilities. And they always were trying to rub it in that they had the lowest dose. We, after doing these studies that showed you can't lower the dose that much, we spent a lot of time talking to them, convinced them to increase their dose. The next time this patient came back, here were these lesions that were very obvious that retrospectively you can see they were there. They were there, but they were missed because they were too subtle. And so this is the problem with going too low of dose with iterative reconstruction or artificial intelligence reconstruction. The images look pretty and the docs don't know they're missing something. So lastly, I'm going to talk about photon counting CT because this is really the next milestone in the legacy of spiral to multi-slice, wide collimation and dual source. In photon counting CT, we have different detectors. So the traditional detectors, an X-ray comes in, makes visible light, you have electrical signals, and the signal is proportional to the sum of all the photon energies. There's no information about individual photons, and you need these walls to stop the spread of light. Now, semiconductor is the material that's used in photon counting, and there's a high voltage applied across it. And when the X-rays hit, they make electron hole pairs that are drawn towards the positive and negative anodes and cathodes, and you get electrical signal. This electrical signal, though, is proportional to the energy of individual photons. So now we know something about individual photons. And this is what the pulse train coming out of a photon counting system looks like. You could look at all the pulses. That would be a low energy threshold image on the Siemens scanner that has this. They call it a T3D. Don't ask me why. You could put a higher energy threshold, and then you have another image, which is also higher energy bin. You can subtract the threshold images and get a low energy bin, and voila, you've got dual energy. And so photon counting detectors are always operating in dual energy mode. The other thing that really works in their favor is integrating detectors put out a signal here on the y-axis that's proportional to the energy. So if we look at the attenuation of iodine, the area that gives us the most signal are the low photon energies, and unfortunately, they don't give as much brightness from the detector. Photon counting isn't weighted by energy, it's only counting those pulses. And so we get a lot more iodine signal. There were a lot of challenges. I'm not going to read this whole list, but it was a tough thing to do. There's a lot of physics that were working against us, plus just how much more data was coming out of the scanner and being able to manufacture these type of detectors. There were some early lab systems and preclinical systems exploring this in the 2000s. And then in 2014, the first whole body, high flux, meaning clinical dose levels, photon counting scanner was installed here at Mayo. This is again Thomas Bohr, and this is Eric Rittman. And we scanned about 300 patients over in this research area. Our first in vivo study was August of 2015. We got the next prototype smack in the middle of COVID, so no ribbon cutting for it. And then eventually we got the third prototype in April of 21. And then in September, on the 30th of 2021, that scanner was cleared for clinical use and commercial sale in the US. And it didn't escape my notice that September 30th, 21 was the evening of the 50-year anniversary of Hounsfield's first image. So for 50 years, we were working with these energy integrating type detectors, and now we have something new going forward. Here's a picture of the scanner, and you can see the clinical state of the art with energy integrating versus this high spatial resolution with photon counting. You can do these coronal images, and what I want to point out here is your dye is brighter in the kidneys because it's photon count weighting, not energy weighting. And it's dual energy. So you can make something called a virtual monoenergetic image that simulates an exam that was taken with 50 keV photons, so monoenergetic. And the dye is so bright, it saturates what you want to see because this is so close to the K edge of iodine. If we change the window and level, we can now see into the liver, and you actually see vessels that you couldn't see before because we've got better contrast resolution at these lower KEV images. Now, spatial resolution, this is the diagram of the detector. In individual detectors, it's 0.15 times 0.176 millimeters, super tiny. And the problem is you've got all these detector pixels putting out 4 thresholds worth of data. They have 4 energy bins. And so that's so much data that the data acquisition stream couldn't handle it. So they have to have less coverage in the ultra high resolution mode than in the standard mode where they bin 4 of these pixels at a time. And again, an image through the lung, the arrow pointing to the bronchial walls. This is an image of the femoral head, and this is state-of-the-art EID system. This is picture from the inner ear, and this is a prosthetic in the inner ear. This thing is less than a millimeter thick, and yet we get this kind of spatial resolution. So our ENT docs will only scan their patients on the photon counting. We see smaller vessels in the heart, and we have more scanning options. We can make this virtual monoenergetic image and see much more of this meningioma than we can on energy integrating. This is the trabecula microstructure that you can see with photon counting, but it's dual energy data, so we can subtract the calcium and actually see bone marrow and bone marrow edema, which is something that previously you could only do with MR. You can quantify the amount of iodine. Here's a pulmonary emboli exam. And this exam is done at a really high pitch value, so it's over in 2 seconds, which is nice if patients have a PE, they can't hold their breath well. And then these are the coronary arteries. There's a calcification at the EID, but you can't really see well what's around it. Is the lumen very patent or not? But with the EID, you can see the calcium. It's brighter because of count weighting, and you can see the lumen next to it really well. But it's dual energy, so we can make different virtual monoenergetic images. We can make iodine maps. We can make non-iodine maps. And so we have a lot more flexibility with always being dual energy data set. One thing that we found is calcifications. This is a vessel in somebody's leg, and there's so much calcium that the signal blooms. We call this calcium blooming. But with photon counting, the calcium blooming is much smaller. And so now you can see that actually the vessel is open. There's a lot of calcium around it, but the vessel is open. And this picture sort of speaks for itself, the different level of resolution that we have for vascular imaging. In terms of dose reduction, I mentioned the inner ear. This is typical at our clinical routine dose. We can decrease the dose and still see this prosthetic better. So some of these exams, we bring the dose way down. I just want to show this image because I love it so much. These are 3 different scanners looking at one of these inner ear prostheses, and this is it on the photon counting system in a volume rendered position. So I know which one I would want if I needed this kind of scan. The other thing we're doing is taking the dose down so low because there's no electronic noise, so your noise doesn't blow up when you get to really low dose levels. And these series of lung images, lung CTs, were taken at a dose that is so low, it's comparable to a chest x-ray. And for kids with cystic fibrosis, they come back once a year for follow-up. They did it with chest x-ray because they didn't want to use CT because of the dose. Now we're using CT, and you can get so much more information from a CT compared to a chest x-ray. So lastly here, I'm just going to show some emerging applications. vascular imaging, there's this really important artery that if you cut it during any sort of spinal surgery, you paralyze the patient. We can see it here and see this sharp bend that the artery does. These over here where the arrows are pointing are little cerebral spinal fluid leaks, and you cannot see them on the energy integrating system. And so we have patients coming from all over the world to get this exam done because their life is debilitated with these leaks. But once you can find them, there's a technique to patch them. And so this has been a really important application. And then I just want to show some AI, convolutional neural network imaging. This is, some would say the future, some would say it's already here now. We are using it to remove noise from images in our lab, not using it to make a diagnosis. Here's an example of cardiac images, typical noise level, and then after our CNN processing. And whenever we compare images like this, we make sure we look at edges and make sure the spatial resolution is not compromised. So this edge is every bit as sharp as it is over in the EID. And then some potential applications with the ability to put this photon counting detector threshold at different energies. You could actually do K-edge imaging and put a threshold above and below different K-edges of different materials, and then be able to tell apart different contrast agents such as gadolinium or bismuth. Problem is, only gadolinium and iodine are approved for use in humans. So this is more of a technology waiting for an application, because right now, just iodine and gadolinium don't give much of an exciting clinical application. You can inject them both and then see the arteries separate from the veins, but this really isn't very popular at this time. And then lastly, the breast is the one organ that we don't really scan with CT. There are some dedicated breast CT scanners, but they are not widespread, and we use mammography and ultrasound, and cross-sectional imaging is done with MRI. Well, we took an MRI patient support, took out the metal screws and put in acrylic. This is the patient laying on it. And we found that if the patient has a silicone implant, those sometimes rupture, and you can find them in these images. That's something that previously could only be done with MRI. We can stage cancers. So the big cancer is obvious. It's this little cancer with the red arrow. So we can see it on CT. And one thing CT did that the MRI didn't do was it has a bigger field of view. And so we found this metastases in the spine that completely changed the patient's treatment pathway. And then lastly, microcalcification, something that people thought only mammography could ever do. These aren't beautiful images on the left, but show that we can see microcalcifications. Okay, so in closing, CT did not die after the introduction of MRI. It just keeps getting better and better. With new technology, though, you've got to critically evaluate it. There's the improved iodine contrast to noise ratio, photon counting, that we can use less contrast media or get improved sensitivity. The new scanners continue to decrease the radiation dose, and the improved spatial resolution has really been a game changer, allowing routine visualization of sub-millimeter anatomy. And so I think new clinical applications are going to continue to emerge. And so with that, I want to give credit to the people in the lab and the coworkers at Siemens, and thank you. I hope you found this interesting.
We certainly did, Cynthia. That was fabulous. Thank you ever so much. That was a real tour de force. And I think you've demonstrated, we are obviously a history society, but you've really emphasized the importance of history in understanding where we are and where we're headed in the future, which is why it's so important. It's not a sort of a sepia-tinged stamp collecting exercise. It's so crucial to understanding where we're headed in the future. So there's a question from Adrian that I'll ask in a moment. I think everyone else has been so absorbed in your talk that they've forgotten to write their questions down. So if people do have questions for Cynthia, please get typing. But I'll ask Adrian's question in the meantime, which is, why is the urban legend that profits from the Beatles allowed EMI to fund the EMI scanner so difficult to eradicate?
Well, unfortunately, it's because it's been repeated in peer-reviewed publications. And so you can find papers that say it. And if that's the paper you go and read, it's there in black and white, so you believe it.
Yeah, well, there's a lot of misinformation around, and yeah, that it doesn't help if they're in peer-reviewed articles, does it? I was interested. I hadn't noticed before. I have seen the lathe bed scanner in the flesh, but I hadn't noticed the turntable that you drew attention to. So that feels like there's a bit of a musical connection there at any rate. And then Adrian has another question. You did not discuss over-investigation and over-diagnosis. Do you have any thoughts on that?
Yeah, that is a real dilemma, because every time a physician finds something that is important to find, their clinical practice mindset is reinforced that it's important to image. I find things I need to act on. With lung cancer screening, it's been shown that lung cancer screening reduces mortality by 20%. But they see things, they think they need to act on them, and so there's a lot of unnecessary lung biopsies. So the professional societies try to make guidelines to help decide when to image and when not, but medicine is a practice, and so anecdotal experience tends to drive one person a little more towards more imaging, and maybe someone else is a little more prudent about it.
I do wonder, you finish up with some fabulous images, but I am wondering how many little lung nodules you'll be picking up on your photon counting scanner, which might be a bit of a nuisance. There's another question from Kimberly, our essay winner. Thank you, Cynthia. I'm a mammographer by background, so I found the information regarding microcalcifications really interesting and could really make a difference as it is developed. I wondered if you had any comment on that.
We are using it right now for women that can't undergo MRI. So we're using it for diagnostic workup, not for screening. It still, I think, doesn't compete with mammography for what you need for screening. But it's been a great assistance to us for diagnostic workup. I think the dedicated breast CT units, and again, Willie Calendar developed one of these with a photon counting detector, they really should have taken off, in my opinion, because then you have the three-dimensional information, and the microcalcifications even better. But mammography is pretty entrenched in our practices, and it was hard to bring this new kid in the block in.
Grand. So keep typing questions in. I have one of my own. You've presented quite a sort of progressive history of how the technology has improved, and those images really bear that out. And certainly on the photon counting scanner, I was very impressed with the doses you showed for the cystic fibrosis patients. I'm a pediatric radiologist, so that looks like a real potential game changer. And it feels like that the technology has helped us in being more relaxed about radiation doses. I appreciate we obviously need to still have some level of concern, but do you have any concerns about the carbon footprint of imaging?
Yeah, that is really just starting to be talked about. The International Society for Computed Tomography has started having sustainability lectures. I'm concerned about carbon footprint of most everything. So one of the things that photon counting has against it is you can't shut the scanner down at night. The rest of the scanners we can, but that detector needs to be at equilibrium for days after you shut it off. And so unfortunately, our electric bill will stay higher with the photon counting.
Okay, thanks. And then
I put in the chat the link to this memorial board for Willie Calendar if anyone wants to comment on that.
Fabulous, thank you. I'm sure there will be some comments. And then, so a question from Jeff is, how important have developments in maths analysis been? We heard some about the maths at the start, but not quite as much as we were getting towards the end.
And you're saying mathematics?
Yes,
okay.
That's right.
CNN, the convolutional neural networks, is sort of all the rage. And there are many things we can do without a CNN. We don't have to, if you have a hammer, everything's a nail. There are things you can do without the hammer. But the success of the AI and machine learning is really moving ahead, to the chagrin of some people that are really purists in the mathematics, that went to great lengths to make iterative reconstruction much better over time, and three-dimensional reconstructions and cone beam reconstructions. So the mathematical purists are a little bit unhappy that now people are just kind of waving their hands and say, I'll throw it into a neural network and see what it spits out. So I think there's a community of very dedicated mathematical oriented folks, but it's a small community and probably going to stay small with AI on the scene.
Okay, thanks. So it's interesting early on describing that the sort of purist mathematical thinking that didn't translate quite into the CT scanner in the way that Hounsfield was more sort of pragmatically minded. So I guess keeping the communication channels open between different disciplines, I think, is really important to help get the best from all disciplines. But I think perhaps on that note, we may need to wind things up. We'll make sure, Cynthia, that the memorial board link is available on our website so that people are able to post comments if they want to. And you also mentioned the video in your talk. We'll try and include a link on that so that people are able to access that as well. So just to conclude, congratulations again to Kimberly and Sam for their prize-winning essays. And thank you so much, Cynthia, for a really fabulous talk. We're delighted that you were able to deliver that for us, and you didn't disappoint. So thank you, Cynthia, and thank you everyone for joining. And we'll finish there. But take care.
All right. Thank you so much. Bye-bye.
Bye-bye.